Yeah. So this was the patient that was admitted to our hospital. She was 75 years old of age. She was female. She complained of multiple skin ulcers. So she was healthy and independent until 7 months ago, where she developed multiple skin rashes, which were mildly itchy and would later ulcerate. These lesions develop gradually on the upper and lower limbs, chest, upper back, neck, face, scalp, but spared the palms and soles. The patient and the relatives report that she is allergic to sulfur, and the lesions started after she received an injection with sulfur-containing drug. It was not sure why she received the injection. So the patient was seen by a dermatologist. The biopsy of the lesions were taken, and she was told the result of keeping is eczema. So she was started on prednisone, and the lesions improved but didn't disappear completely. Yeah, I'll pause there.
Can you go back to the first slide? So the HPI, the first slide of the HPI. Okay, so a healthy and
This is the first slide of the HPI.
okay, so a previously healthy and independent 75 years old female, right? Until 7 days prior to
Yeah.
presentation, when she starts to develop multiple skin rashes, which were pruritic, and then later on they ulcerate, and they started involving the upper and lower limbs, the chest, the upper back, the neck, face, scalp. They're also involving the scalp, but they are sparing the palms and soles. And the patient and her relatives report that okay, she's allergic to sulfur, and the lesion started after she received an injection with the sulfur-containing drug. In the next slide, okay, so a diagnosis of eczema is made. She started on prednisolone, and the lesions improve, but they do not disappear. So that's the HPA, Joseph, right?
Yes, David. That's the first part of the HPI.
Okay, so this is the first part. Okay, so a skin condition here, and uh, yeah, I mean there are thousands of differentials when it comes to a skin rash. So Joseph does not mention any constitutional symptoms here, but when someone presents with a skin rash, the thoughts are that whatever we are seeing is either coming from the outside, which means so basically it's something that is coming from the outside, or let's just say, let's use another schema, that it's something that is just involving the skin, or the skin is just part of something multi-systemic. And so when we think of any a skin condition, there can be infections of the skin. Maybe I should use a very basic schema. It can be an infection of the skin. So you can think of many infections that involve the skin. And then we do have drug reactions. That's not a skin infection, but a drug reaction, and we have many of those. So like a drug reaction with eosinophilia and systemic symptoms, and then and many other drug reactions like SJS10, that is Steven Johnson syndrome, and toxic epidermal necrolysis. All these occur on a spectrum. Those are examples of drug reactions. And then I mentioned infections, drug reactions. Another one is it could be something, it could be an allergy. Now, a drug reaction is something when someone is allergic to a drug, then the skin presentation is because of that allergy. But then some people have allergies to a number of things, and they come into contact with those things, they develop a skin rash. So for example, here we are seeing a diagnosis of eczema. Now eczema has a typical presentation, and I know that it's not absolute that you have to see this in order to make a diagnosis of eczema, but a textbook presentation that we note is that a patient with eczema presents with a pruritic rash that involves the flexor surfaces of the upper limbs as well as lower limbs. So on the upper limbs, it involves the cubital area, and then on the lower limbs, we see it more commonly on the just behind the knee. So in that area. And but yes, it can also involve other areas. You can see it even in the neck and other areas. So it's a rash, pruritic, and of course it's I mean, I'm not sure, but so eczema is something that I mean can occur at different time points in life, but commonly you see eczema even starting, I think more commonly starting during childhood, and therefore we expect someone to have a long history of this illness and not something that uh, comes abruptly at 70. But so that is based on my limited knowledge, and I'll be very happy to learn anything new, whether we can make a first diagnosis of eczema in a 75 years old female. So I talked about infections and drug reaction, and then so what I put, I loosely use the term allergies, and then of course you can have autoimmune diseases which present have a skin presentation. So we know SLE has a skin presentation. Dermatomyositis or inflammatory myopathies in general has a skin presentation, and then also you can count the blistering skin conditions like bullous pemphigoid, pemphigus vulgaris, and others as autoimmune conditions. So I think it's still something very still very broad right now. But since the patient has an administration of a sulfur-containing drug and then having the reaction, uh, well, we could take that as part of the explanation. But then so this presentation was 7 months ago. There is no disappearance of this. So I still questionable whether it was just an acute reaction to a drug that is still lingering around more than 7 months later. So I think still very broad, and I haven't uh, made my mind on anything specific. So let's continue in order to see if I can make progress. But it's tough.
Yeah, thank you very much. And we also questioned the eczema 70-year-old female, so the same as you. So there's part two of this HPI. So a few months from the onset of the rash, she reports gradual weakness of the upper and lower limbs. She said she couldn't raise her upper limbs as she used to, and her walking pace kept decreasing to the point of needing assistance. But there was no numbness or paresthesia. There was no blood or bowel symptoms. She denied of any low back pain or neck pain. And 2 months ago from this admission, she started to present with difficult swallowing solids. There was no problem with liquids. She reported that after chewing food, it was difficult to initiate swallowing. Food kept roaring in the mouth. There was no sensation of food being stuck in the chest, and the dysphagia wasn't progressive. There was no facial weakness, double vision, or change in voice. Any update on that HPI daily?
Yeah, let me see the previous slide. So a few months after the onset of the rash, she reports gradual weakness of the upper and lower limbs, couldn't raise her upper limbs as she used to, and her walking pace okay. However, there are no sensory symptoms, as it seems, no sensory symptoms, no blood or bowel symptoms, and then no low back or neck pain. And then the next one, so 2 months ago, 2 months again, she starts presenting with difficulties in swallowing solids. And after chewing, so the problem is initiating swallowing. However, there is no sensation of food being stuck in the chest, and the dysphagia isn't progressive. No symptoms that are suggestive of. So basically, I should say, no other symptoms that are telling us maybe this is something bulbar. Okay, so I started with something else earlier, that when we see a skin condition, maybe one of the questions, and of course this could be, maybe it's an incomplete question, but the question is it something that is just involving the skin, or is it a systemic issue, and the skin is just a part of the presentation? So what has unveiled afterwards makes me think that this is something systemic, and the skin is part of the presentation rather than just something involving the skin alone. And we always, I believe, many times we've said this, that there are two systems of thinking. So that's according to some people, especially. So there's this author of Thinking Fast and Slow. So if you've heard that book, there's system one and then there's system two thinking. And system one is the intuitive kind of thinking that serves us, or that takes us through most of the day. Because when you come across things, you do not unleash your effortful thinking that, okay, what I am seeing here. So for example, when you see cars, you can intuitively say, okay, this is a RAV4, this is Discovery, this is this, based on past experience, and it's just reflexive. So I'm tempted. Part of me is convinced to utilize system one thinking, because I'm seeing a presentation here that there is muscle weakness, and therefore past experience tells me that I see muscle weakness plus the skin, and inflammatory myopathy comes, I mean, is part of the presentation. I shouldn't say high on the list, but part of the presentation. However, because the kind of weakness that is described here involving the upper and lower limbs, we haven't heard about difficulties, for example, in rising from a sitting position, but we are told that the patient has difficulties in raising her upper limbs than she was able to do in the past. And that makes me think of more of a proximal muscle weakness, which is in keeping with inflammatory myopathies. So, in inflammatory myopathies, dermatomyositis, polymyositis. So that is reflexive. That comes reflexively. Now I see something else here, that is difficulty swallowing solids. So the difficulty, and just I think that was so the case that Joseph shared, and the case that Roland presented to me, was a case of dysphagia, which I struggled with a lot, but it reminded me of the schema that I used to solve that case. That dysphagia, we can categorize it into oropharyngeal and esophageal dysphagia. And this to me sounds more like oropharyngeal, because the patient is having difficulties in initiating swallowing, rather than having something stuck in the chest, which of course brings some questions, because by pattern recognition, if we see um, someone presenting with features in keeping with a myopathy, and then we see a skin presentation which was more of a rash, and then followed by ulceration, I mean, we could talk about an inflammatory myopathy itself, like dermatomyositis, or it could be an overlap with something else, or part of a mixed connective tissue disease, and therefore carrying in association with scleroderma, for example. And scleroderma can come with esophageal dysmotility. And this is where I'm having the difficulty. So basically, if it's esophageal dysmotility, then it will be more of esophageal dysphagia rather than oropharyngeal dysphagia, which oropharyngeal dysphagia makes me think of something which is neurological in origin. But of course, a primary muscle issue can also come with dysphagia. So I think I have a number of possibilities to think through here. So So what is going on? That is what it makes me think about that. What we are thinking is more of a myopathy, sounds like a myopathy, and therefore tallying with the skin presentation could be something like dermatomyositis. Now, the skin presentation of a pruritic rash, which later on ulcerates, gives me some questions. It involves the scalp, it involves the face, I believe, the neck, and then the upper back, the limbs. So the rash that we see in inflammatory myopathies, we have the classic rash that we talk about, a heliotrope rash, Gotron's papules, and all that. Well, it's a rash. So the issue of ulceration and the being very extensive makes me question, that is it just a rash that is associated with dermatomyositis, or is it something else? But that is just a thought. So I think if I have made any progress, is that maybe what we are dealing with is not an isolated skin condition, but a systemic issue. And this systemic issue, at least as of now, we know that it involves the skin, it involves the muscle, and let's say the GIT, but it could be we end up in the muscle. So one of the thoughts, as I said, an inflammatory myopathy, and it could be an overlap syndrome that is involving an inflammatory myopathy and then in association with another autoimmune disease or connective tissue disease in general, like scleroderma. We haven't heard about skin thickening, but we'll see. So let's progress, Joseph, so I do not waste more time.
Yeah, that's a lot of learning from you. Let's see the next. So the global system, they reported significant weight loss, which I termed like 7 kilos from the onset of the illness. But there was no cough or shortness of breath. There was no chest pain, no abdominal pain, diarrhea, or constipation. She had hypertension and she was on medications, including fixed losartan H, amlodipine. She was also on the prednisone that the dermatologist started. She was also on mupirocin topical on the skin ulcers. Also, she told us she was allergic to sulfur drugs. Family and social history: she was a retired military. She was a social drinker. She didn't smoke cigarette. Her first degree relatives were in good health. I'll include this general exam because the case is long. So when I saw this patient in the ward, she was alert and oriented. She was not febrile. She was not pale. She was not jaundiced. She didn't have any lymphadenopathy. And she had some bilateral pitting lower limb edema. The vitals were within normal limit. The skin exam, she had ulcerations on the gluteal and the inguinal regions. They told me these were not the rash, the skin ulcers that were there before. They came after prolonged illness. So I thought maybe pressure sores and stuff like that. But it's up to you to tell me if you think otherwise. Also, what we saw of the skin ulcers that they told were healed from given steroids, I only saw post-inflammatory lesions. So I didn't see the primary lesions that started 7 months ago. And these post-inflammatory lesions were on the face, scalp, upper chest, upper back, extensor surface of the upper arms, and the extensor surface of the hands. Also, there was the post-inflammatory lesions on the legs. Neuro exam, her higher centers completely normal. The cranial nerves are also normal. The power was 3 out of 5 in the muscles of the proximal upper limbs, but were normal in the muscles of the distal upper limbs. The same, there was 3 out of 5 in the muscles of the proximal lower limbs, but normal in the muscles of distal lower limb. The tone, deep tendon reflex, tone and deep tendon reflex were normal. The plantar reflex were mute. Coroners was absent, and she had a normal sensation, sensory sensations. Other exam, respiratory system, CVS, pulmonary, abdomen were all normal. I think we can discuss this.
Yeah, so something else that we see is the patient has weight loss. Now, So weight loss, we can take it. I think we've talked about weight loss a number of times. The question is, this patient could be maybe because of the dysphagia that she's having, and therefore there is reduced intake. That could be one explanation for the weight loss. But another one is impaired malabsorption, which would not see in this patient. There is no diarrhea, nothing that is pointing us in that direction. And another one is an increased metabolic rate, so an increased basal metabolic rate, or a catabolic state, as we see in patients with inflammatory conditions. And yes, many inflammatory conditions, including some that are uh, under consideration in this patient, can present with weight loss as part of the constitutional symptoms. So I think a number of explanations for the weight loss. And then with the medications that she's on, we believe she has been on those medications for a long time. So there's she's allergic to sulfur drugs. But then I find it hard to explain. I mean, if someone is allergic to the drugs, when they exposed to the drugs, we'll see a reaction. But that reaction causing a picture in keeping with the myopathy, I think if there's something of that sort, I'll be happy to learn that today. And then, so coming to the, because when we are dealing with the skin condition, there's a number of things to be thought about. Of course, a detailed medication history, which we have here. We know she's allergic to sulfur. She's on other medications which we do not think they cause any problem, because we believe she has been on those medications for a long time. And then the prednisolone is added for the skin condition that she has presented with. And then it's also important to inquire deeply about the family and social history, including occupational exposure. So she's retired military. I mean, I will find it. I will find a hard time to think about an exposure during her military career that would present with a skin condition like that, because there are some occupational exposures that can cause people to present with certain skin conditions. Another one, of course, is recreational activities, the kinds of activities that people have to do, because these can expose them to some infections and other things that or even exposure to things that they are allergic to and present with a skin condition. So I do not see anything that is of importance. I'm finding it hard to, especially thinking about a military career, the fact that she's retired. Maybe there is nothing from that history that can explain her presentation. So coming to physical examination, the yeah, I have the same thinking that the ulcerations on the gluteal area could be pressure sores, and even in the inguinal region if the patient is lying in the prone position sometimes, because otherwise I find it hard to explain that these ulcers could be because of something else. So I'm thinking probably pressure sores, but of course I should admit that it's I do understand that the anterior superior iliac spine is another pressure point there, and therefore if this patient is lying supine, I mean prone, there could be ulcers there. But this could be a signal that is pointing me in the direction of the underlying condition, but then the eyes can't see what the mind doesn't know, and I could be missing a signal here. So post-inflammatory lesions on these areas do not tell me much, but the fact that there are lesions in the upper chest and back, you can think about some signs that are present in patients with inflammatory myopathies. So like shoal sign, V-neck sign, you see those in patients with inflammatory myopathies, and that could be a possibility in this patient. The V-neck sign as well as the shoal sign. So those could be the issues. And So another thing I already talked about eczema, and its typical presentation that it involves the flexor surfaces. What we are seeing here is the extensor surfaces, which I think betrays eczema, but no absolutes. So I cannot be 100% sure that we can rule out eczema from here. But I mean, everything in this patient's presentation, it doesn't convince me of eczema. So uh, coming to the systemic exam, we've already talked about it. Right from the history, I had a suspicion that this is more of a proximal muscle weakness, and that has been confirmed by neurological examination that it's more of a proximal picture. And I should say that proximal muscle weakness is not, yes, we say so something that is on top of the list, a myopathy. That's a myopathic picture, but you can have it even in other conditions. I mean, so when you talk of muscle weakness, you should remember the entire neuraxis, that it can be something that is coming out of the CNS, the brain and spinal cord. Well, I find it very hard to think about a brain pathology that presents with just a proximal muscle weakness, and of course it's asymmetrical. It's a symmetrical proximal muscle weakness, very difficult to think about it. And then the spinal cord, uh, a, and then an anterior horn disease or a motor neuron disease. Again, very difficult to think about it just presenting with a proximal muscle weakness. So I see it to be more of a picture of more of a myopathic picture rather than something else. But Joseph, if you have some other differentials for a predominantly proximal muscle weakness, I'll be happy for you to remind me here. So I think that is where I am, that the systemic examination has just helped us clarify a number of things, that we are dealing with a proximal muscle weakness, which I consider to be more of a myopathic picture. And then the post-inflammatory lesions that also involving the upper chest and upper back, those could be some signs of an inflammatory myopathy. So the issue of the ulcers, I'm considering them to be more of a pressure sores, but as I said, I could be missing some signal here. So let's proceed in order to see if I can make any progress or refine my thoughts.
Okay, very nice. Lots of teaching from you today. So let's proceed. Here are the labs. Pretty unremarkable. White count normal, HB platelet also normal. Renals were normal. Electrolytes, she had hyponatremia of 123, normal potassium hypochloremia of 91. And the RBG was high when she was in the ward, it was 14. So this patient, this is the OGD that was done when she had dysphagia. So it only showed gastritis. And she was given PPI and she was sent back to the DEMA clinic. The DEMA guys sent to the gastro when she developed dysphagia. Can you discuss this maybe?
Yeah, so the labs that I'm seeing there, the sodium, and of course I think I missed something that you told me earlier, that this patient has hypertensive heart disease, but then on examination she had a pitting lower limb edema. Also, at least in the physical examination, there was nothing that was telling us whether this patient was in failure or not. I mean, we didn't hear anything of that sort. But the lower limb edema can be explained by a number of things. So, this patient is on steroids. Steroids are also known to cause fluid retention. And amlodipine, now we are not sure if this lower limb edema has been there for some time, but calcium channel blockers like amlodipine are also known to cause lower limb edema for some patients. So in absence of symptoms that are telling us that this patient is in heart failure, and then we see normal RFTs here. The creatinine is normal, so a renal pathology is not likely. And then the issue of reduced intake, of course, there's another issue about albumin, but then I think the presentation is not very dramatic to make us think that maybe this patient has hypoalbuminemia. So I think could be from the drugs, the prednisolone, the amlodipine, and then the hyponatremia. Now it's because the other labs they seem unremarkable, and then you see hyponatremia here. Now I'm thinking a number of things. I think I'm making a lot of hypotheses here, but one could be this patient has hypertension, and therefore, so for some, you could find that the patient is on salt restriction, and because they are told to restrict salt intake, some of them will stop taking salt altogether and present with hyponatremia. That is one explanation, and then of course we have many other causes of hyponatremia that I think at this point I will not go to discuss. But then uh, an association between hyponatremia, the muscle weakness, not very likely. So if it was something to do with potassium, we could discuss that the potassium could be one explanation for the muscle weakness. But sodium, of course, there is no direct link. But again, I'm trying to keep time because Joseph has told us this is a long case, and therefore, I think I will not discuss some issues in details, and this could make me prone to miss some important issues that could be signals. So if I miss anything, Joseph will teach me. The elevated RBG, the hyperglycemia, uh, because we were not told that this patient was diabetic to begin with. So one explanation is that if this patient has been on prednisolone and we do not know the dose on prednisolone for 7 months or no, and or 7 months or more, and we are not sure if there have been any efforts to taper this prednisolone dose, this could be one explanation for the hyperglycemia. Of course, we know that diabetes can present with many things, including diabetic neuropathies and many other things that even muscle weakness. I mean, in a far-fetched manner, you could also explain it with diabetes, but then I think the closest explanation we have for the hyperglycemia is the prednisolone that she has been using. And the OGD showing gastritis. So not very much, at least it tells us that it's not an esophageal pathology, and we were not considering esophageal pathology to begin with. We thought more of oropharyngeal dysphagia. But as I said, it could be esophageal dysmotility, but could be another thing to do with myopathies coming also with now with if we talk of a myopathy, of course we would expect that the presentation is also is esophageal dysmotility rather than oropharyngeal dysphagia. So let's see if Joseph, you have any other labs, anything else that could make us that could help us make progress.
Okay, let's proceed. Um, so the thing is here, this patient was admitted now to our hospital because of this slide. A week prior to the admission to our hospital, she developed acute onset of shortness of breath. She was attended at another hospital, and at that hospital, they did a chest CT with contrast because of the dyspnea, and it showed multiple nodular opacities in the left upper lobe and along the pleura, bibasal septal thickening, which was associated with ground glass opacity, mediastinal lymph nodes, bilateral pleural thickening, and the right pulmonary artery filling defect. I think you can discuss this slide and tell me what you think about the diagnosis of this patient.
Okay, so is that where I commit to a final diagnosis,
Yes.
or we still have some other pieces of information that can help me make progress?
This is the final slide.
Okay. Yeah, so an acute onset of shortness of breath. And so, well, there are many differentials of shortness of breath that we could discuss, but because the patient has imaging here, we'll use this image and maybe work backwards to see what can tally with the other presentation that the patient has. So the CT is showing multiple nodular opacities in the left upper lobe and along the pleura. Okay, and then there's a bibasal septal thickening with ground glass opacities, mediastinal lymph nodes, bilateral pleural thickening, and a right pulmonary artery filling defect. Okay, this is interesting. I think it's a very busy slide to unpack, but I should say that there's a number of things to be thought about. So you know one risk of pattern recognition is that sometimes you, because it's effortless, and therefore sometimes you try to explain everything that you see with the closest available information, and when you do that, so when you do that, you can miss some important pieces of information that could lead you to the right conclusion and miss the bus completely. So this rather acute onset of shortness of breath. So I should start by saying one thinking that I was thinking about is we are considering an inflammatory myopathy, so dermatomyositis as one of those, and of course a close relative is polymyositis because of the muscle presentation and then the skin presentation and the dysphagia at the periphery. So when you think about those inflammatory myopathies, it could be easy to discharge this shortness of breath and the CT findings that you see that, okay, these autoimmune diseases are commonly associated with interstitial lung disease. Oh yes, that is one of the pulmonary presentations of the autoimmune diseases. So we could be dealing with interstitial lung disease, but then the picture that we see here is that there are some nodular opacities. There are nodular opacities that are seen in the left upper lobe, and then along the pleura, they are nodular opacities. And so when you think about nodular opacities on a CT, and then of course in association with the mediastinal lymph nodes that we see there, I think it's prudent to also consider a separate inflammatory condition that has its own right presenting in the lungs. And so when we open this box, we should consider infections, infections like tuberculosis, for example, and this patient could be prone to that infection because of the immunosuppression from the prednisolone that she's using. But then, of course, we did not hear a strong signature of fevers, night sweats, and of course, this could also be attenuated by the prednisolone that she's using because it's anti-inflammatory. So something like tuberculosis, but then tuberculosis will not explain. Tuberculosis will not explain the muscle weakness that we are seeing. You should also consider a possibility of other infections apart from mycobacterial infection, like endemic mycosis, which could present exactly the same way, nodular opacities, and then the mediastinal lymphadenopathy. But again, those ones will not tally with the muscle weakness and the skin presentation. So when I skip infections, another one is autoimmune diseases, which would mean that the dermatomyositis or polymyositis that we are thinking of explains the muscle symptoms, explains the skin presentation, also explains the pulmonary presentation. But then I'm thinking that so the pulmonary presentation that I think about commonly is interstitial lung disease. Maybe not these nodular opacities, and this could be something else like a malignancy, So because we see there is mediastinal lymphadenopathy, and then there are nodular opacities, and so the nodular opacities. The only caveat that I see here is that there is bibasal septal thickening, and there is a bilateral pleural thickening, which are so when you think of a malignancy, so it's something that, for example, especially if it's primary, then it could be isolated to one side. So why am I considering a possibility of a malignancy? Because of the nodular opacities that we are seeing here, and then the presentation of an inflammatory myopathy that the patient has. Because one thing that we should remember, although of course it will be a hard time to tie them together, inflammatory myopathies can actually be a harbinger, or they could be telltale signs that there is an underlying malignancy. And that's why when some patients are diagnosed with an inflammatory myopathy, some clinicians will make efforts to try and rule out, to make every effort to see if this patient is not having any malignancy, because inflammatory myopathies are associated with malignancies. They could actually be an outward presentation of a malignancy that has not been diagnosed. Yes, so Joseph, I think this final slide has not made my work easier. It has actually complicated it, because I'm thinking, is it a presentation of a is it a pulmonary presentation of an inflammatory condition, an autoimmune disease to be specific, or is it a picture of a malignancy that is also presenting with an inflammatory myopathy? So I think those are my two thoughts, and I will not make any efforts to be more specific beyond that. So I think I have two major possibilities. That one is we started with an inflammatory myopathy, and the inflammatory myopathy is what is explaining the other presentation, explaining the skin, explaining the muscle, including the difficulty in swallowing, and the pulmonary presentation, which is actually the one lowering my confidence, because I think this is not what I would expect from an autoimmune disease. And then the other way around is that we are having a malignancy somewhere that is presenting with an inflammatory myopathy as as just one of the presentations. So I think those are my two major thoughts, and uh, I find it hard to move beyond there. So I'm just waiting to learn from you. Very interesting case.
Yeah,
Thank you.
David, are you still speaking?
Yeah. So I think just reveal the diagnosis and teach me. Interesting case. Difficult to move beyond there.
Yeah, before we reveal the diagnosis, if you can, because when they say down there, right pulmonary feeling difficult, I think you need to see that they
Uh,
mean there was pulmonary embolism on the
yeah,
right.
yeah, yeah. So
Can you?
I did not discuss that definitely. So when there is a feeling defect, we should consider a possibility of pulmonary embolism, and I can't think of anything else that because this is CT with contrast, and there is a feeling defect that has been seen, so we should consider the possibility of pulmonary embolism, which now makes me think this patient, you've told us, and there are some pressure sores that there are some pressures also which are telling me that probably this patient is not very ambulant, and that is one of the explanations. So definitely pulmonary embolism is one of the things that need to be considered in this patient.
Okay, so most of it is on spot on. As Plus did discuss, and I think Nebo is on fire today, putting a lot of good teaching points, and that I think if you would be reading them, it would be more and easier for you. But it's you've done a very good job. So I will tell you our case resolution, which won't be far from what you were telling us. So yes, although the patient had was allergic to sulfur, the rash plus other symptoms can't be explained by sulfur allergy, as David told us. So we suspected that the skin biopsy showed there was inflammation on the skin, but it required the doctor to figure out where it came from. And the dermatologist thought it was eczema. We strongly disagreed with the diagnosis early on. So because new eczema in a 75-year-old is highly unlikely, as David told us, this is childhood and that has to be there before. But the crucial thing was that if there was a neuro exam in that 7 months ago, maybe information could have changed to the place that David is talking about, because weakness early on can be subtle. So patient came to us because of dyspnea, and she didn't have a primary rash by then, but proximal muscle weakness and dysphagia pointed us to inflammatory myopathy, as David is telling us. And we also saw dermatomyositis is the one more likely due to the presence of the rash. And this rash was not there because she was given steroids, so it responded. And so they told us they did CT in another hospital. And when we looked at the report, we saw that feeding defect, and the radiologist suggested there was a PE on that part. And as David correctly was saying, radiologist also questioned that this can be a malignancy. So radiologist offered that if patient can have a biopsy. But we wondered, the patient was not on any anticoagulant. That's why she also had another dyspnea at home and came to us. So we gave the patient rivaroxaban, and she responded very well. The dyspnea went away. So as you're telling us, once you diagnose inflammatory myopathy, you should screen for malignancy. But the CT was there. It was telling us that there is suspicion for malignancy. Do biopsy. So the malignancy also would explain the pulmonary embolism, because malignancy is an hypercoagulable state, plus a patient who is bedridden, highly likely chance of getting a pulmonary embolism or DVT. So after managing this patient, we sent her to Palmo Clinic. Just that the patient has to have a biopsy, a pleural biopsy, but they also thought, the surgeons, I think, they also thought she wasn't stable. So until now, she doesn't have a biopsy. So yes, final diagnosis like you, David, we think this is probably lung or pleural malignancy with dermatomyositis, spinoplastic syndrome, and pulmonary embolism. Some few learning points. So dermatomyositis, a refresher, will present with symmetric proximal muscle weakness with a characteristic rash. Also, other symptoms can be there or they cannot be there, like dysphagia. This was there. ILD, interstitial lung disease, inflammatory arthritis, constitutional symptoms like weight loss and others. And it is highly associated with underlying malignancy. Once you see a patient with dermatomyositis, like if this patient had early on diagnosis when she was still stable with a rash, if someone thought this is DM, the next step was to find the malignancy. And it's not difficult. You pan CT them first of all. You do a CT check. Maybe I presented the case to David. I don't know if David remind me if we recorded it. A patient with also polymyositis and a new rash on the plantar surface, which she didn't care. But when I looked at it, I said, this is suspicious. And she went outside of the country. Turned out she had melanoma. Suicide in old age. As you age, the risk increases in female sex. So some labs that we didn't do include muscle enzymes like creatine kinase, LDH, aldolase, including dermatomyositis. ANA is positive in up to 80% of patients. And you can also do muscle-specific antibodies. They're not available here, but they also take longer to come back. But for the purpose of learning, these include antisynthetase syndrome, anti-MDA5, anti-NXP2, and others that are still being discovered. They are there to tell you the syndrome because there are so many types of dermatomyositis, but diagnosis, you just make it clinically. So skin finding is important. David is telling us about Gottron paps and others. When I looked at the post-inflammatory lesion, I didn't see the primary lesion, but when I looked at it, it was not in keeping with the dermatitis. And then I took my time and learned about the skin findings. And this major teaching points in this. Yes, Gottron papules and heliotrope rash, if they're pathognomonic, I'll show the pictures. But others include Gottron sign, facial edema, shoal sign, V sign. So, for example, cutaneous ulcerations. I didn't know this, but it's also common in a subtype which is called anti-MDA5 associated dermatomyositis. So this patient had this. I'm not sure, but also they say in the literature there are others. So if you see rash that you don't know, dermatologist, maybe it wasn't maybe characteristic, but if you see rash, proximal muscle weakness, dysphagia on top of it, I don't see anything else apart from dermatomyositis. So that's it, I think. Then here are the some of the pictures. As you're seeing on the left side, this erythroid rash that's can be on the upper lid, but can be periorbital. The Gottron papules, these two are pathognomonic on the extensor surfaces of the metaphalangeal and PIPs, as you're seeing there, but others include Gottron signs, shoal sign, V sign on the chest. So yeah, the treatment usually, if severe, like in this patient, you have to start with IVIG and you go for steroids. But if it's not severe, you just go straight forward to steroids and some response. This rash, you see, she was given prednisone. I think they started with 80 and then they tapered and the rash responded. But then weakness, dysphagia came up. I think she needed IVIG or high doses, which include IV steroids. So if there is a malignancy, you treat an underlying malignancy. So for this patient, you must have a biopsy and prove there is a malignancy so that you can treat the malignancy. So patient can be normal. If you don't treat the malignancy, there will not be good prognosis. So reflection from me, David, before I give you the chance, is that one, we should strive to treat patient as a whole. Like you see this patient, 7 months, dermatologist seeing them, biopsy comes back and saying inflammation, and then being treated. But these relatives told me the weakness started when they were still going to the dermatology clinic. So dermatology would have thought that no, this is not usual eczema. Why is the weakness? And then at a point she developed dysphagia. They were taken to gastro. Gastro just did OGD, said gastritis, go back to dermatology clinic. So this is not a good practice for me because someone has dysphagia. They've been brought to you and you've done OGD and there is no explanation. They expect the result from you. So why is they having dysphagia? Maybe you can come up from there. So I think maybe whatever the training will go, but we have to treat a patient as a whole. And general doctors, the GPs, and us, the internists, this is the major role of us. And the other thing is that always, I try to do this every time. Also, sometimes it's hard, is to ask why. Like, why is the rash that looks like eczema starting 75? Is why? Why are they having ulcers? Why, if given steroids, going away? Why later developing proximal muscle weakness and dysphagia? Is there something? If someone asked why, for example, 2 months from the onset of the disease, this disease could be captured early on, and at that point, before the biopsy, maybe you could have been having the results now and treating the patient for cancer. So yeah, back to you, David.
Thank you very much, Joseph. Sad for the patient. Interesting case for learning, and thank you very much for presenting it and for the reminder. So I always tell people that I'm in close contact with that the issue is, a good quality medical care starts with a correct diagnosis. It starts with a correct diagnosis, and you make a correct diagnosis by paying attention, taking a good history, examining the patient well, because even investigations, if you just send investigations randomly without anything in mind, I mean, there are lots of incidental findings there, incidentalomas. That's a word for it. So so if you just order investigations without focus, you might end up seeing some abnormal findings that you fail to explain, and therefore you may end up over investigating the patient if at all the patients can afford the investigations, or you order investigations that are not helpful. So it starts with a good history and a good physical examination. And yes, so another thing is, that's why I find that being a generalist is something very good, especially in situations like these ones. So for everyone who is I mean, it's specializing is a good thing, and I think those people are very helpful and we need them. But then, even after super specialization, do not let the generalist in you die, because otherwise we might end up compartmenting patients that. So I'll just deal with your dysphagia. If I find nothing wrong with your dysphagia, then you do not have an issue. Go back to the dermatologist because you have this skin condition. And so you find that patients will make many rounds to and from the hospital without a diagnosis being made, and maybe it could be something curable, or at least if caught earlier, the prognosis would be better. But then there's a delayed diagnosis, and then management becomes more complicated. So thank you very much, Joseph, for sharing the case, for us to learn from it. And I think those are very good reminders. I had a hard time, but very grateful for the learning that I had. And I checked the chart after committing to the diagnosis, and I see, of course, Nebo, Noel, are very good inputs there that would have made my work easier earlier on. And that's very very discerning of you to make the diagnosis just from hearing the history. So very interesting, and thank you everyone for the contributions. So we are a few minutes past the hour. If there is anyone with any comments, anything you'd like to contribute, any experience that you'd like to share, please welcome before we close.
Okay, I have a very little contribution and maybe an experience that I had, if I'm allowed to share.
Yes, please welcome.
Okay, thank you so much, Dr. Joseph, for a very beautiful case. You know, clacking from tracing back to the history of the patient, it's really that somebody could have missed. But what I've learned from this case is like, you know, the few cases that I saw, especially the skin manifestation, comparing to this patient, really, they don't really tally with the dermatomyositis skin presentation. Most of the cases, one that I saw, they present with what we call, it's like a poikilodermatous lesion. You see the lesion which are hypopigmented and hyperpigmented, but it's like the patches, they are more of patches, hypopigmented and hyperpigmented lesion. And also, Dr. David talked about some of the pathognomic features like the Gottron papules or the heliotrope rash. Sometimes, if the case is very fresh, it's when you can appreciate. But if the patient had maybe many days, it is very hard sometimes to pick them. Yes. So I had one case that I saw, I think it was a 20 years old female and was diagnosed with a left-sided breast CA and was attending one of the, it was attended by the oncologist at some point, but when now he was referred after he developed the typical presentation of dermatomyositis as Dr. David presented. Proximal muscle weakness, but also later he started developing this dysphagia, but also at some point difficulty in breathing. And when now he was diagnosed and he was initiated on the treatment, the issue was that now he should go back and start the treatment. But now that was like a battle now that, no, please, you should treat this, control dermatomyositis first when we can initiate the treatment. So, you know, that was where the conundrum was. But as Dr. Joseph said that, you know, as from this case, that initial treatment, the malignant at the underlying cause is the initial control. So I think as clinician, maybe we should understand that this, you know, it's like a teamwork. So maybe we lacked the discussion at some point, but unfortunately now the other breast also succumbed, features of breast here again, and we lost the patient at the middle. So thank you very much. That was just my little contribution. Thank you.
Thank you very much, Nebo. That was very insightful. And please let me just take this time to remind everyone we are beginning the new year. We need the cases that you see. So you see, Dr. Nebo, you had a very interesting case there, although very very sad for the that we lost the patient due to some delays in decision making. But interesting cases like those, we can learn from them. So if anyone has a case, whether complete or incomplete, that you think we can learn something from, please summarize it and reach out to me or to Joseph, and you will definitely get a spot for you to present it to the audience, and we get time to learn from it. So I do not see any other hand. Uh, if there is nothing else, welcome back, everyone. It's the new year. We had like a 2 weeks break. Now we are back. I think unless there are any issues that are beyond our reach, but otherwise every Sunday at 8 p.m. we meet here. We'll be sharing the link. So we have some newcomers today. People from the group, you can see that the group where we share links, there are many people who joined. So we have people who are joining these sessions for the very first time. So please welcome. We welcome you very much, and we are happy to have you around. We'll be sharing the links. We do these sessions every Sunday at 8 p.m. unless stated otherwise. So looking forward to having you around many more times. So if there is nothing from anyone, it was good having you today. Good to see you. Happy New Year and have a good night. See you next weekend.
Good night.